Thank you for that insight. That's really helpful.
Yeah, thanks.
We're going to have Dr. Rec Mateus, because actually I think it's his last day here. I don't know, Dr. Almeida, if you'd like to introduce him.
Yeah, so everybody, good morning. It's a pleasure to introduce Mateus. Mateus is a last year medical student from Rio Grande do Sul in the south part of Brazil. He spent 2 months now with us here working with Dr. Quinones, myself, and our entire team. And today he did a great work. Mateus, thank you very much for joining us. And Mateus is also a leader in medical students, initiatives in Brazil, and organizes actually a bunch of business meetings related to medical care and medical education in Brazil. So great work on that end as well. And today he has the challenging task to present a very interesting case we had recently here at Mayo. And I want to thank also Gianna, who helped to organize the video and edit the video, and Diogo, who also helped to supervise Mateus and to help with this. So without further delays, Mateus, let's see what you have for us.
Sorry, I was mute. Thank you, Dr. Almeida. Thank you, Diogo, for the kind presentation. Can you guys see my screen?
Yes.
So, my name is Mateus. I'm a final year medical student in Brazil, as Dr. Almeida said. Today, at first, I would like to thank all of the people involved in the care of this patient, Dr. Almeida, Dr. Chaichana, Dr. Donalds, Dr. Lumo, Dr. Goyal, sorry, Dr. Murray, Dr. Gentov, and Diana and Diogo also for helping me to prepare this presentation. Our case starts with a woman, 55 years old, who was previously healthy, but throughout the last 4 years, she started to present with daily headaches, and she also reported a worsening during the last year. In December of 2021, she had an episode of a excruciating headache that made her search for medical care. At this time, she had a CT and MRI that demonstrate a skull-based tumor. And at this time, she was advised for conservative management with repeating imaging every 3 months. Unfortunately, we didn't have all these previously exams, but we have one from March of the last year. Here to present you, we can clearly see an extra axial lesion here. From more specifically the inferior and medial part of the clivus. Sorry, I think it's here. This one's better. And he's also clearly compressing the brainstem. I don't know, Dr. Almeida, do you want to comment now or later?
Yeah, we can see the next images, but as it's possible to observe, it's a lesion center in the clivus with enhancement of contrast that is well delineated with well-shaped borders, extra-axial in nature. And therefore, number one hypothesis, and I would say 2 and 3 would be, a meningioma arising from the clivus. In cases like this, and we're going to see the more recent images, so to further discuss, but the big question is really where this tumor is apparently arising from. And in my opinion, this one is really arising from the midline, like a true clivus meningioma. And that certainly so plays a role in our decision-making, additional to a few other features that we can see with the images you're going to show ahead.
So here, Shikara at Mayo in December of 2022, After worsening of her symptoms, she reported at this time of fatigue, and also she started with swallowing issues, especially for solid food. She also had some balance changes, but we denied any falls, denied also diplopia, hearing change, facial weakness, or any other motor deficit that could be implied with the localization of this tumor and its potential involvement with the lower cranial nerves. After this consultation, she had a exam here at Mayo. So, sorry, also the neurological examination, a part of this alteration was mostly intact. This is the exam that you have here. Dr. Murray, I don't know if you want to make some comments on those images.
Sure. So as you scroll down, kind of as already described, you have an extraaxial, dural-based, homogeneously enhancing midline mass arising from the clivus. You can see it extends down to C1, C2 right there. There are dural tails, which is usually venous congestion, right? Not tumor, but can be seen in other tumors, but certainly is most characteristic of meningioma. I mean, just like was said, this is meningioma 1, 2, 3, 4, and 5. I mean, you can give a differential. There are other dural-based lesions, but it looks like a typical meningioma. I think what's more important here is describing its relationship to important neurovascular structures, such as the verts. There is mass effect on the medulla, as you can see. It's also intimately associated with the kind of cranial nerves 9 and 10 as you go down, the lower cranial nerves, and 12 as well. I think it's covering the hypoglossal canal. Not any vasogenic edema. And to what vasogenic edema usually typically means when there's a lot of it, it's a stickier tumor and it's a typical, it's harder to get kind of the plane when I'm told. I wonder if you guys could confirm that, but that is, that's basically it.
Here at the, thank you, Dr. Murray. At the coronal cut, you can see the displacement of the basilar artery.
Yeah, like in cases like this, just to complement, like when we look at this image, and I saw that in her home state, she was advised for conservative management. And unfortunately, what happens is that, you know, when a tumor gets this size, it continues to grow. It's hard to measure, but it continues to grow and cause symptoms. And she is young. She, you know, helps to take care of her husband. And she was developing symptoms. Those symptoms included the headaches, you know, dysphagia now for solids, and she was starting to present with balance changes. So she's starting to present with the issues that, you know, even some surgical complications could lead to. And then we look at this mass, and the sagittal that it's pretty good there, shows that this tumor is located, as we said, in the clivus, and the clivus are divided in 3 parts. When at least that's one division that I like. And then we look at this part. This is what I would call, this is upper clivus. This is here. We're gonna get, I'm sorry, in this area here, we would get the mid clivus, and then below this area, we're gonna get the lower clivus, and then you got the craniocervical junction itself. So in this tumor, we would have the impact around the mid clivus, lower clivus, and going all the way close to the, so this is the dens of C2. So this is the odontoid process. So when we look at this type of case and we think about the different approaches that we have, and Mateus is going to go through that in a second, 2 points we have to consider. In terms of the nasal anatomy, we see this line of the palate with the base of the odontoid. And you see that in this case, I'm sorry, with the base of the clivus, you see that there is a good line, a good angle of approach that can benefit us. And even you see here the soft palate, and we can even like mobilize this with the dot to get even a lower exposure. The one big caveat when we think about approaches is that we got to remember that the craniocervical junction also has its stability secondary to the ligaments located between the apex of the dens and the clivus. So we don't want to disrupt that to the best of our abilities. So that would be one point that plays a role in our approach. The second point is, if you look in the axial, Mateus, please. Scroll. Yeah, you can stop there. You see that this being, stop there, please. Stop there. Yeah. If we look at this one here, this tumor, as we discussed, apparently really arises from the clivus and then expands laterally to both sides. The one challenge, of course, is, as Dr. Murray mentioned, it goes towards the hypoglossal canal on both sides, and that one, it's challenging. But the second challenge, and more importantly so, is that it goes up and pushes the, the lower cranial nerves on both sides laterally, and pushes the 7 and 8 complex both sides laterally, and also pushes the 6th nerve forward and laterally. So when we look at all of that and we think how we're going to approach this patient and how we're going to manage this patient in terms of, managing the tumor directly, we have to consider those details. And then one has to think, well, how much can I potentially safely resect, how I can do that more safely, and what is going to be my way. In this case, if you come from lateral to medial, so the classic transcranial approaches, you have the cranial nerves, and those are important to be considered, of course. We're talking here about facial nerve, here vestibulocochlear nerve, 9, 10, 11, and 12 cranial nerves, which are certainly still very, very important. When we think about the midline approach or the nasal endoscopic approach, we're thinking about chances of issues with not only subtotal resection, which is also an issue with transcranial approaches, but also the chances of post-op CSF leak and meningitis, which are the two significant complications I would share in cases like this. So those are points that we need to consider. But Mateus, please go ahead, and we're gonna further discuss in a moment.
We have the tissue. You can see a lesion that its relations with the vessels, the vertex and the basilar. The coronal one.
Okay. I'd like Dr. Olomo is here. Noma, are you here with us? I think I saw you.
Yes, I'm here.
Hi, Noma. Good morning. So, Dr. Olomo, I mean, as we were saying, just for the sake of time, we've been thinking about, and we discussed how to manage this one. And I'm sorry that the sagittal that we have is just this one, but Mateus can scroll the axial. Would you share with us, when we discuss about this case, what we consider when exploring the CT scan and the anatomy of the nose of this patient in terms of management and how to mobilize the structures?
Well, the big question is, how much exposure can you get safely in a tumor like this? Just like you said, without destabilizing the ligaments. This tumor is primarily behind the clivus, and so we know that we're going to need to go primarily not really transsphenoidal, but really transpterygoid, in this case. So moving apart most of the tissues of the nasopharynx and creating what we call a U-shaped flap, where we make an incision superior and laterally, and then just peel that soft tissue down, which is quite a bit of tissue just to get to the clivus, because most of our work is actually not within the sphenoid sinus at all. Looking at nasal, we're looking at nasal cavity for things like septal deviation or any other things that we'll have to get out of the way. But truly, this is just planning for a transclival approach.
Thank you.
Thanks, Noam. Appreciate it.
Now entering the realms of the differential diagnosis, as Dr. Murray said, that this is a very typical meningioma, but for educational purpose, we could also think about durametastasis, a solitary fibrous tumor previously known as a hemangioperistoma, or maybe a secondary lymphoma. We cannot think about things like osteosarcoma, because we can see that it's not growing properly from the bone. It's came from the dura. And I don't know, Dr. Murray, if you want to say some things about the differential diagnosis.
No, that's perfect.
Thank you. The patient also underwent an swallow assessment with a barium swallow fluoroscopy that was positive for a moderate oropharyngeal dysphagia, which was consistent with the localization of the brain tumor and its involvement with the brainstem. Potential options for treatment would be the conservative management, as she were doing this last year, surgery or radiotherapy, but in order to improve the clinical status of the patient, compress the mass effect on the brainstem, and also to offer tissue for diagnosis after a multidisciplinary discussion. Surgery was the chosen option. As potential approach, as Dr. Almeida was saying, we could have a endoscopic endonasal transclaval approach, a petrosectomy, or a heterosigmoid craniectomy with far lateralization that would involve a much more maneuvers and contact with the cranial nerves and adjacent structures of the brainstem, cerebellum, and the brain itself. So the minimum invasive option, the endoscopic and endonasal transclaval approach, was chosen. Dr. Almeida, do you want to comment on that? No?
We talked about it briefly. Let's go to the videos. Yeah, we selected endoscopic endonasal to try to maximize the bulking of the tumor, with the understanding that we would not be able to fully remove this tumor due to the lateral extensions and the challenges in some of the details of the reconstruction, and also because of the instability in the cranial cervical junction. But we still favor that one, considering that we really want to minimize potential additional neurological deficits, and we felt that the midline corridor would allow us to do so. Let's check the videos for the sake of time, Mateus. So Dr. Longo, if you want to start.
So I'm just decreasing the middle turbinates, removing the concha bullosa there just to create more access. We know that this case is going to have a CSF leak, so I'm going to start with elevating the flap. So there I performed the sphenoidotomy on the left side. Because we're going transclival, we can't keep the flap in a nasopharynx. So I'm going to open up the maxillary sinus here to create a space to essentially store the flap during the surgery. It also improves access transnasally, removing those tissues. Same thing on the other side, reducing the middle turbinates, create more room. And then now I'm going to outline the flap with the bovie. So bringing the incision inferiorly towards the floor of the nose, and then now creating the superior limb of the flap. Now I'm going to elevate the flap with a suction elevator on a caudal, and then store it in the nasopharynx. So now that that's done, so they're storing the flap in the nasopharynx. We then extend the sphenoidotomy inferiorly towards the clivus. It's like it went back a little bit. Oh, there, yes. So, keep going. Yeah, keep going. So extending inferiorly, I'm going to get the sonopet next, and then start removing the rostrum of the sphenoid sinus and really focusing inferiorly, trying to get that transclival window set up. So there's the rostrum of the sphenoid sinus. Now the sonopet is going to drill through that. In these larger cases, I will essentially completely remove the posterior septum to create a wide approach. And so there you see the sella, and now drilling the floor of the sphenoid sinus. I'm now using a bovie to make those incisions in the nasopharynx, just lateral to the teres tuberous, or in the fossa of Rosenmuller. It's a very vascular tissue, so we use bovie a lot to bring down that U-shaped flap I discussed earlier to expose the clivus. So with this approach, you get a very wide curve to the clivus. And then now it looks like JP is going to start with the extending that transclavial approach posteriorly.
Yeah. So here, basically, as we discussed, so we're working from in the mid-clivus after that beautiful exposure by Dr. Lomo. And so the mid-clivus is basically below the floor of the sella, all the way to the floor of the sphenoid sinus. And then that's the first part of the work. And as you see here, the usual diamond drill with a square shape opening in the dura, so we can get a good visualization of the bone edges. And then after that, we continue exposing inferiorly all the way to the edge of the occipital bone. And then what you saw there, we were drilling some of the occipital condyles, doing what we call a formedial approach. So we drew the medial part of the occipital condyles to get that corridor. You saw the dura being opened in a linear fashion. And because of the approach we selected, this tumor is already fully devascularized. So you're going to see that despite being fully devascularized, which is the good part of it, it is also extremely fibrous as a tumor. So we have to work with micro scissors to start removing. And well, we know it's a meningioma. I mean, some of them we are lucky and they're soft and we can debulk quite extensively with without ultrasonic aspirator. In this case, we needed to use everything we had. So you see here, as we wait for the ultrasonic aspirator to be ready, trying to use scissors and to use a microshaver, the Nico device. And the Nico helped a bit, but too fibrous for the Nico device. So we had to work with really scissors. And here you see that working right in the core of the tumor. And then we got the sonopad, but you see I'm waiting for the endoscopic sonopad tip. So this is the classic sonopad tip that we're using at this point. And then it helped a bit, but didn't allow the proper angles of approach. So I had to continue working with micro scissors. So that's what you see there. So that's why it was a somewhat time-consuming procedure. And then micro scissors and cutting and really taking time to work around that, but really going in a centrifugal shape. So going from the center towards the edges. Now we got the endoscopic sonopad, and that can work more extensively due to the different shapes and tips and size of the instrument. In fact, we further expand the bone work towards the really edge of the clivus, and then as we work with the sonopad, we got to all the way to the posterior part of the tumor. We got all the way to the most cranial or the top edge of the tumor. And then we try to push as much as we can without mobilization of the carotids, to get the lateral aspect. We were very happy with the cranial part. We were happy with the caudal part, considering that we knew we were not going to get to the odontoid. And I was, let's say, semi-happy with the lateral aspects, that we were somewhat limited due to the lateral extensions. And the fact that the ultrasonic aspirator that we have for that. Can you stop the video for a second, Matheus? Because that part that you're showing is an important one. Because the ultrasonic aspirator that we have, it in the market, by the way, not here, it's in the market. We don't have one that has curved curved tips for that. So that would be lovely to have one of those available in the market at some point for cases like this. Because in a very fibrous tumor like this, you really rely on the ultrasonic aspirator. There is absolutely no chance that would be possible in different ways. The option is to remove more bone laterally, but then you also have to incur more chances of CSF leaks. And I think that as we go, we're going to be removing more bone laterally and exposing the carotids and mobilizing the carotids. But it's always a thin balance. So go back a bit just to show the reconstruction, because this is a very, very important part of the surgery. More. Okay, stop there. Yeah. Okay, so the play. Okay, Dr. Lomo, would you like to describe, please? The reconstruction was very, very nice.
deciding how to reconstruct this was a challenge. It looked like there was only a very small amount of CSF egress inferior on the right side. So put some fat on there, then fascia lata. No real bony edges to tuck it under. So put the fascia lata there, brought the U-shaped flap superiorly, and then onlaid the pedicles nasal septal flap on there. I then further filled the sinus with some fat around the edges, and then put some tissue on there, which looked like an appropriate reconstruction. But as you see, it's always a challenge. Everything was then tucked in with gel foam and appeared to be quite stable for a few weeks.
Perfect. Thank you, Dr. Olomo. Let's see, Matheus, what happened afterwards.
Dr. Gentaf, do you want to comment on the pathology? In the line? I don't think he is.
He's in the line. I don't know. Dr. Gentaf, can you hear us, sir? Yeah.
Can you hear me now?
Yeah.
Sorry, I'm having a little trouble with my connection. You can see all the pink material here. That's collagen deposition, or the fibrous tissue that you were talking about, and that's why it was so fibrotic. But we do have meningothelial cells here that are forming a tumor, so it looks good for a meningioma. You can see there's an arrow present, and that's highlighting a little secretion. So this meningioma does have some secretory features, and there was no mitotic activity. So it's a grade 1 meningioma.
Thank you, Dr. Gentaf. Grade 1 meningioma. Here is the postoperative CTs. You can see the lateral part of the tumor and the central part that was resected.
Go to the MRI, just for the sake of time, because we're running out of time here. We want to show the second part. You can skip that. Yeah, so this patient had a lumbar drain for 5 days and did well in terms of the reconstruction. You see in the sagittal that in the central part of the tumor, you can even scroll a bit more, Matheus. We got like a very nice, that's right in the midline. So here we got this very nice area in the center with a very thin line in the top that we knew about it. I could have resected this with no problems. We decided to keep it just to keep that line of protection in the bottom part as well. And as you're gonna see in the axial, show us the axial, please. The axial was really the limitation. So that's stuff right there, yeah. So you see in the right part that we have this residual, and then the left part, the same thing. And then it's nice, you can see the nasal septal flap there that is vascularized, which is a good sign. So go to the next slide.
So the patient was doing clinical well, no evidence of CSF leak. The lumbar drain was clamped and the 6th day after the surgery. And she cursed only with a SIAD during the 9th day of postoperatory, but she was treated with tablets of salt and restriction of fluids. The swelling assessment was much improved after the surgery with no definite aspiration during the study. She was discharged 14 days after surgery, but was readmitted 2 days after the discharge with a sudden onset of the altered mental status. The Glasgow Coma Scale was of 14. So here we can see that.
Yeah, I'm gonna help a bit just to expedite this. She had this massive pneumocephalus, certainly so due to a CSF leak in that clival region, right? So with this massive pneumocephalus, we really have to manage that. And then the way to manage that, the first step, you can, it's really to place an EVG to drain some of that and pneumocephalus, pneumoventricle, and to stabilize the, her neurological status. That was done. She did well with the EVG. And then we took her to the OR for endoscopic and nasal exploration. The EVG was on the night before the endoscopic repair. And so we did endoscopic repair the day after with the assistance of the help of Dr. Donaldson. This is the video that we did for this case. So we harvest once again fat now from the left leg. And you're gonna see that the issue that we found there, this is just cleaning the, the grease from the previous surgery, so some gel foam surgery cell. The CSF was coming from the left angle between the nasoseptal flap and the U flap, and a bit also from the right side. So this is just Dr. Don's cleaning between the two spaces. And then here I'm placing a suture between the edge of the U-shaped flap, the vascularized nasoseptal flap, and the eustachian tube. So this is just a technique. You have to put this is a 4-row neural suture. You bring the stitch out and then you carry on the suture line towards that area. Then I'm gonna put a second stitch to hold that to the eustachian tube and kind of like to triangulate and to close that pocket. After we did that, then I grafted I got some graft from fat on the left leg. Dr. Donuts, you see here, she's just trimming some of that U flap to kind of get some vascularization. We packed that fat graft and we placed it underneath the vascularized nasoseptal flap. And then I placed 2 or 3 more sutures on the right side now, connecting the vascularized septal flap to the U-shaped flap and also to the top of the eustachian tube on the right side. Of course, the idea is to keep those 2 angles clamped and to minimize issues. Then, after that was done, she placed a layer of durability biodesign on top of that fat graft, and then we placed this, which is a right-sided lateral nasal wall flap or inferior nasal turbinate flap that is also vascularized and to help to accommodate in between the nasoseptal flap, U-shaped flap, and now you have the right side inferior turbinate flap as well. And then some Duracell to keep these structures in place. And this was the end of the suture, of course, with packing with nasal pore and so. So after the surgery, she thankfully so did well. She's still here in the hospital with us, so we're following her closely. She kept the EVD for about 7 days, and now she is off EVD. She's in the floor, and we're following her closely to try to help. Of course, she has risks of infection because the leak and many other different issues. So we're still keeping a close eye on her. Thankfully, so she's neurologically intact, and we are, still keeping an eye on her before getting her out to rehab.
Thank you, everyone. Thank you, Dr. Almeida. Thank you all.
Thanks, Mateus. A very nice presentation. Thanks, Dr. Lomo, for being here with us today. Very, very nice case. We have to find some easy cases from sometimes.
Yeah, so the pairs are challenging. Just one quick thought. Those tissue edges that Dr. Almeida was very expertly sewing together typically will heal very quickly within 12 to 24 hours. But I find that whenever patients have any kind of metabolic disturbance, either SIADH or poor nutrition, or if that healing is slowed for any reason, you can end up with a situation like this where the flaps just don't adhere together and you can create a space for a leak.
Yeah, I just want to add to that comment, the other thing that, and she, of course, she is like thin. I mean, she's not, she just has problems with nutrition, I think, because of that. That may play a role here. I agree with Dr. Lomo. And the other thing is, you saw the size of the mass. It's kind of like some degree of obstruction in the ventricular system. And I'm still wondering if this patient is not going to get, a VP shunt, in fact, because of that. Even despite the bulking that we did, that she may still be someone that may end up requiring that. So, food for thought for afterwards. Once again, thanks everybody. And Diogo, share us like what we're going to have this Monday, please.
Absolutely. So thank you everyone for joining us today. Next Monday, we're going to have Dr. Brown, Desmond Brown. He's a Mayo Clinic Rochester alumnus. He's now an assistant clinical investigator at NIH, and he'll be talking to us about primary cilia, exploitable GBM signaling hub. So please join us everyone next Monday, and then Friday our usual series. Thank you, everyone.
Thanks. Have a very good weekend, everybody. See you.